Hello and welcome everyone. My name is Sally Pinto and I'm from the Yonkers Newark Neighborhood Naturally Occurring Retirement Community. We launched back in January of 2020 and we're here to serve seniors 60 plus in Northeast Yonkers. We have lots of fun programs and activities, and we also have a lot of resources for you as well. Our programs include meditation chair yoga, body mind fitness, bingo, and any other programs that you might be interested, like arts and gardening. We have our resource specialist, Alexa Smith, who can help you with finding services and activities out there for you, as well as our nurse, Barbara Simone, who can help answer your health-related questions. We're here for you, we're here for our community, and we look forward to seeing you in our programs. Enjoy.
Hello, everybody. I'm Alexa Smith, the resource specialist with the Yonkers Newark. I'm here to help with application assistance, referrals for home delivered meals, and transportation services will be coming soon. We also offer Zoom activities and Zoom programs. And if you have any other questions or concerns, I'm here to help. Thank you so much and enjoy the program.
Welcome. I'm Barbara Simone, registered nurse. I recently retired from Westchester County's Health Department as a public health nurse. I am now here to try to assist you with any medical or preventive care issues. Enjoy this program, and I'm looking forward to working with you.
I have Lisa Holland, who's from the Community Affairs Department here, who've been working with closely ever since January to bring programs to our community. And I'll take it away with her. Morning, Elisa.
Good afternoon, Sally, and to everyone. On behalf of the leadership of New York Presbyterian Lawrence Hospital, we welcome you. In observance of Breast Cancer Awareness Month, we wanted to talk about the importance of mammograms. And also just to remind everyone that breast cancer does not only affect women, it also affects men. So I'm glad there's some men on the call today. We will be hearing from Dr. Lynn Chinitz momentarily, but as some of you know, I'd like to give you an overview of the hospital before we hear from Dr. Chinitz. The Lawrence Hospital Center, which is now known officially as New York Presbyterian Lawrence Hospital, has been around since 1909. In 2018, we became an official campus of New York Presbyterian. What that means to you, frankly, is access to more resources, clinical trials. We've got doctors from Columbia, specialists that we didn't have before, that can now provide all sorts of services, whether it's a consult in the office or a surgery in our new state-of-the-art operating rooms. So we're very excited about that partnership and being part of New York Presbyterian. There are some wonderful things that we'd like to talk about. We have a Commission on Cancer, a certified cancer center, and there's one of our state-of-the-art operating rooms I just referenced. We have a cath lab that has saved countless lives. People have come in with heart attacks and they've been resuscitated and gotten stents and other interventional procedures. And so we're very excited about that. And we're also doing some interventional stroke procedures as well. Of course, we're all very much aware of COVID-19 and how it's impacted our lives over the last 9 months. And we just want to remind everyone that our hospital and medical group offices are safe. We have instituted new protocols. Everyone is required to wear a mask when they come into the hospital, when they walk around the halls. We are restricting the number of visitors in our hospital. There's a lot that we're doing in alliance with the New York State Department of Health and of course the CDC. So don't delay care. If you need care, you should absolutely get care and feel safe and feel comfortable about doing that. New York Presbyterian Lawrence Hospital is very committed to community service. We offer free lectures like this one. We also have support group meetings for people who've survived cancer, those people who've just had babies, and for people who've had strokes. So on to our speaker today. She is Dr. Lynn Chinitz, and she is a board certified radiologist who came to us, I don't know, Lynn, it's been over a decade now, But she is currently the director of the Carol H. Taylor Breast Health Center at our hospital. Dr. Chinitz is also an assistant professor of radiology at Columbia University Irving Medical Center. Dr. Chinitz has devoted her entire career to the early detection and diagnosis of breast cancer. As director of breast imaging at New York Presbyterian Lawrence, she helped establish the Carol H. Taylor Breast Health Center, which, by the way, it was on the other slide, but I'm going to remind you again, it is a breast imaging center of excellence, and that was awarded by the American College of Radiology. Dr. Chinitz is a graduate of Barnard College. She earned her medical degree at SUNY Downstate College of Medicine and graduated with honors. She completed an internship and residency at Beth Israel Medical Center and a fellowship at St. Luke's Roosevelt Hospital Center. Please join me in welcoming Dr. Lynn Chinitz.
Hello, everybody.
Hi, Dr. Chinitz. We can hear you. You can go ahead.
Okay. So are you going to advance the slides?
I will. There you go.
Okay, so today I'm really going to focus on finding breast cancer early and screening mammography, because this is the first fight against breast cancer. It's not a cure, but this is how we're going to find cancer early, and I'm going to focus on screening mammography, and we'll have time for questions afterwards. So you can go to the next slide. So what is the goal of breast cancer screening? It's to reduce deaths from breast cancer. And how do we do that? We find the cancer early. And by finding the cancer early, the treatment is more effective and it's less harmful. And that is our goal. So we're talking strictly now about screening. You can go to the next slide. And screening means that patients, you do not have any symptoms. So first we'll talk a little bit about things you should know about breast cancer. Breast cancer is the most common cancer in women. It's the second most common cause of cancer death among women. 30% of all cancers in women, and 1 in 8 women will be diagnosed with breast cancer in their lifetime. I know this is a retirement group in Yonkers. Well, breast cancer increases, the incidence of breast cancer increases with age. Typically, younger women have a more aggressive types of breast cancer. African-American women usually have less of an incidence of breast cancer, but typically they would get their breast cancer can be found younger in African-American women, and it can be more aggressive. So we really have to be strong in our fight and encouraging everyone to have a mammogram every year. And we have reached our goals because people are surviving breast cancer. Why? Because we have early detection. We find it before it has spread throughout the body. And now we also have improvements in treatment. Next slide. Next slide. Now, these are some of the risk factors, and you can see there's a lot of risk factors for breast cancer. You can go to the next slide. Some things we can do to decrease our risk of having breast cancer, such as we can exercise more. We don't have to sit down, we have a more active lifestyle. Unlike me, I'm always in my chair sitting all day, so I should learn from this slide. Have a healthy diet. Try to not have, be healthy in your weight. Alcohol decrease your alcohol consumption. But other things we can't do much about. And that's the inheritance part where there's genes, people inherit the breast cancer, BRCA gene from their families. Also, just having an increased incidence of breast cancer if you don't have the BRCA gene in the family history. As you get older, as we said, the incidence increases, so we can't do anything about that. We want to get older. Also, we're going to talk about this is very important, breast density. And we don't have any control about how our breasts look on the mammogram, and we're going to review that. And also, what causes the increased incidence of breast cancer slightly is having estrogens around. So people who have a late onset of menopause, or they give birth to their first child after the age of 30, or they begin their menstrual cycle very early. They have a longer time of estrogen in their body, so they have a slightly increased risk. You can go to the next slide. You have to realize, and I think that a lot of people don't realize this, is that 75% of all women who develop breast cancer will not have any family history of breast cancer or any of the other factors that put them at risk. And that I can't tell you how often somebody will come to, I'll tell them, give them the sad news that they have breast cancer, and they'll say, but I don't have any family members, or I don't have any risk factors. But that in itself is a risk factor. Being a woman and getting older, those are our risk factors for breast cancer. We can go to the next slide. How do you get cancer? Cancer is obviously, it's multifactorial. So there's harmful exposures in our environment. We have the gene mutations, and that can be from the BRCA gene. And then, as we said, our lifestyle. Can go next slide. And here's an example of cells on the left side of the screen. You can see these are the normal these are normal cells. And what happens in breast cancer is they have an uncontrolled amount of growth and multiplying. We don't have those, we don't have the other cells, which are called tumor suppressor cells or tumor suppressor genes, to stop the growth of these cells, and they rapidly grow. Next slide. Now, this is a basic slide saying what is in the breast. We have fatty tissue, and we have most of the breast tissue is made up of fatty tissue and fibroglandular tissue. You really don't have much control about how much fatty tissue or how much fibroglandular tissue you have. Weight does have a little bit to do with the amount of fatty tissue, but not the amount of fibroglandular tissue. So we have lobules, and then there are ducts within the lobules, and we have the fatty tissue, and the stroma is called the stroma. Next slide. So what happens in breast cancer is that if you look at the top right, you have a normal milk duct. And then what happens is you have this uncontrolled growth within this duct. And cancer can stay within the duct, and mammography has found these very early breast cancers called ductal carcinoma in situ. And these cancers can eventually become invasive cancers where they can spread outside of the duct. But these cancers, if they're found early, are 100% curable. And mammography has found, since the onset of mammography, we found a lot of ductal carcinoma in situ, and that's the earliest form. It's called stage 0 breast cancer. But then as breast cancer grows and as the cancer cells grow, they spread outside of the duct, and then they can spread throughout the breast and through the lymph nodes and then to the body, which is called metastasized. All right, next slide. I know I said most of this, we're going to talk about screening for breast cancer. That means you don't have any symptoms, but just to note some of the symptoms of breast cancer. And the most common symptom is having a lump. You feel a mass in the breast. That could be a pea, it could be an almond, or you can have one breast starts to look bigger than the other breast. You can see an indentation in the breast when you look in the mirror. You can have bloody nipple discharge. The nipple can start turning in, it's being pulled in. You might see some redness or swelling of the breast, but it usually is not painful. When it's painful, it's more likely an infection, but redness and swelling can be a sign of breast cancer. And they call that peau d'orange, which is the orange peel skin. You look also for dimpling. So it's a good idea every day or every month, you raise your arm up, look in the mirror and see if you have any of these findings in your breast. Okay, next slide. But as we said, the goal for this talk is the early detection and effective treatment offer the best chance of survival for breast cancer. Because of mammography, back one for a second, because of mammography, the mortality rate has decreased by 40. And this is, we'll see the graphs, and this has proven because that breast screening has saves lives. Okay. This is on the right. You'll see that we're missing some of this slide, but I just want to tell you, besides finding the cancer small, and that's our goal in the breast in mammography, is to find the cancers small before you can feel them. So we want to find the cancer before you could feel them. There are different types of breast cancer, and that's what's limiting. The typical, and we're missing this on this slide, but the most common cancers and the ones we hear about are called estrogen and progesterone receptor positive cancers. Those are the cancers that are treated with anti-estrogen medications such as tamoxifen. And those are the cancers that are the most common. Then we have other cancers called HER2 positive, and that's the Herceptin receptor. And that's a little more aggressive type of cancer. Those cancers are treated with a special focal chemotherapy that targets these Herceptin receptors. And that, so that's a targeted type of medicine, targeted type of treatment for those cancers. And then we have a triple negative cancers. And those cancers don't have the Herceptin or the estrogen and progesterone. So besides for finding it small, the different types of cancers will affect people's prognosis. Next slide. But you can see, even with the various types of cancer, when it's local and stays within the breast, the 5-year survival is 98%. So that is our goal, to get the 90 to find the cancer when it's within the breast. Next. So what does it mean to screen? Screening means it refers to the regular use of certain examinations or tests in people who have no symptoms of the disease. So we are going to screen, we encourage all women to come every year for a screening mammogram. And this way, when they have no problem. Now there are various different types of screening tests. Colonoscopy could be a type of screening that, you might have a colonoscopy every 5 years or every 10 years. And every screening test that you have is for people who have no symptoms. But some screening tests could be more dangerous than others. But screening mammography, the risk of developing breast cancer from x-rays is practically nil, especially when you're over 50. When breasts are not rapidly developing, the X-ray radiation really has no impact on the breast tissue. Next, please. So this is our famous study that we all like to show. And you can see that when mammography started in 1987, there was the stable amount, the mortality of breast cancer hasn't changed. But since then, we found a 42% decrease in mortality from mammography. Okay, next slide. So our screening, this used to be a prettier slide, it didn't go through. Our screening, we recommend, that's from the American College of Radiology and the Society of Breast Imaging, is that we recommend starting mammography at age 40. I'm going to discuss the different other recommendations, but this is what we recommend. And our health insurance guarantees that you can have an annual mammogram and start it at age 40. And screening interval, that means how often you're going to have the mammogram, is every year. Now, when do you stop having a mammogram? There is no studies have shown when to stop having a mammogram. So if you're healthy, and you're even 80 years old or even older, and you have 10 years, if you have a healthy and you can live 10 more years, it's estimated that you will live 10 more years, you should still have a mammogram every year. With that in mind, you have to realize there's no point you can have a mammogram, but you also have to think of what kind of treatment am I going to have if we find something. And sometimes in an older patient, we can find the cancer and then they choose not to have surgery or radiation, and they just have the tamoxifen, and they could take a pill, and this will keep the tumor small. So you don't have to do any curable treatments, but you have to do just to limit the side effects of having a breast cancer growing. So we really encourage women who are healthy to come every year. Next slide. This is just a comparison, and you're going to hear a lot about, I'm sure, in the newspaper, and everyone has a different opinion. There's all these different agencies, the American Cancer Society, the American Medical Association. They all have the Association for the OBGYNs, that's ACOG. They all have different recommendations, but every group has stated that starting mammography at age 40 has saved the most lives. And you can see in the first column is what the American College of Radiology and the Society of Breast Imaging is what I prescribe to. There's no age limit to stop. And we recommend every year to have the mammogram. The American Cancer Society recently came out with their guidelines. They say you can talk to your doctor if that's starting at age 40, but they recommend 45. And they say that's where to stop screening when your life expectancy is less than 10 years. And then they say 1 to 2 years after you're 55. We don't really believe in the logic to that, because we don't want to miss that point where it's too late to find the breast cancer and then treatment won't help. Okay, next slide. All right, so I'm showing you the slide on the left is an illustration of what's in the breast, and the slide on the right is an X-ray of the breast. And I'm gonna show you this because I'm gonna show you some mammograms and you're gonna see how we look for breast cancer. So you can see that we can see the lymph nodes, they're on top. You can see the ducts and the glandular tissue, they're white, and the black is fat or gray. This is important because breast cancer is white. So when breast cancer is white, it can hide within this glandular tissue. Next slide. You can go next. All right, so what is a mammogram? A mammogram is a low dose X-ray. It's called 2D digital mammogram. This is your typical mammogram that you are used to. There's 2 views that are taken called the CC and MLO view. Those are the standard 2 views because not one view can include all the breast tissue on the image. And what happens is that the breast is pressed between the 2 plates. We flatten the breast tissue, we flatten the breast, and we spread the tissue for better visualization. We have to put the breast in compression so that there's no movement of the tissue, and also so that we can spread apart this dense tissue, this fibroglandular tissue, which is white, that can hide the breast cancer. So that we compress because we care. We call it really snug fit. It shouldn't be painful. And a mammogram, this is when you are brought into the room from your technologist. You're usually in a gown. When you come for your mammogram, you shouldn't wear a dress. You should have like a top and a skirt or a top and pants, because you just take your top off, you put on a gown, you come to you speak to the technologist. They'll bring you into the room and discuss with you. They'll probably ask you what your date of birth is for the 100th time that you've come into it. But they're going to discuss with you, and this is a good time to discuss with the technologist if you have any issues like a frozen shoulder or you have a bad back, and they'll conform to your limitations how to do the mammogram. And then we have the 2 images, and then the images are sent to me in the computer. I'm in a different room. I'm in the room that I'm sitting in right now, and I'm usually in pitch black. And then I will look at the mammogram. And typically what we have at our center is that patients who come here are very lucky in that I'm going to look at the mammogram while they're still here. Other centers, you'll have your 2 views of each breast. You'll go home, the technologist will look it over, make sure everything's okay. You'll go home, and then if you need to come back, they'll call you back. But here I try to look at everybody who comes. So if I see anything, I can then do another picture if I have to. Okay, next slide. And this is just a cartoon. Yes, I did have my mammogram today. Why do you ask? You can see her breasts are flattened. Okay, next slide. When you come for your mammogram, don't use deodorants. We don't, because a deodorant could look like what I'm going to show you, calcifications on the mammogram. So make sure your breast is clean, no skin, ointments, nothing even under the breast or under your arms. And as I said, you wear 2 pieces of clothing. And people say you should, if you still have your period, maybe wait after a week after your menstrual cycle, your breasts are less tender. I know that sometimes people say their breasts are extremely tender and it's very difficult to have a mammogram. We recommend, if you're allowed, you can take some Advil or Tylenol before you come. Maybe that will help. But most people really don't complain of the compression of a mammogram. Next slide. So what do we look for? These are 4 typical things of what I'm looking for on a mammogram. As a mass, what we call calcifications, architectural distortion, and a developing density. And I wanted to show examples of each. Okay, next slide. So when we look for a mass, we look to see the margins of the mass and the shape of the mass. Is it round? Is it oval, lobulated, irregular, spiculated? As you can tell, we go to the right, the risk of the mass being cancer increases. And this is what I'm looking for on the mammogram. I'm looking for this mass, and I'm going to say no suspicious masses are seen if there are no masses seen. Next slide. And these are examples of masses. So the one on the left you can see is a round mass. It's not so white. It is white, but it's not so white. And that is a typical finding, most likely of a cyst. The one in the middle is an oval mass, but it's very dense. And the one on the right, you can see is spiculated and irregular margins, and that's the typical appearance of a cancer. Once we find a mass on the mammogram, we then would do what we call a diagnostic workup to see what is this mass, and we'll typically take the patient into an ultrasound room to see what kind of mass it is. Next slide. And this is an example of an irregular mass, if you can see. On the left is what we call the CC view. In the middle one is the MLO view, and there's a zoom up, and you can see this is a small irregular mass. We don't see the margin so well. If you could see it on the right, I know I don't have a pointer, but this is a small mass, and that's the goal of finding breast cancer. Okay, next. And this is what this mass would look like on an ultrasound. What we do, an ultrasound is not used typically for screening. Maybe for dense breast it is. We'll discuss that when I discuss dense breasts. But this is an ultrasound is used to characterize the mass. And we could tell if a mass is a cyst or is it a solid mass, and then how it looks. Is it irregular? So this mass here is irregular, and that was the mass that we saw on that mammogram. Next slide. We also look for calcifications. I'm only showing here malignant type of calcifications, calcifications that are a typical sign of breast cancer. Almost every single mammogram has calcifications in it. So don't be surprised if you have calcifications. Almost every mammogram does. Most calcifications are benign, but this is what we look for. In the old days, we would take a magnifying glass and look up and look at the screen to see the calcifications, because they're very tiny. They might be hard to see. So, but now we have the capability of zooming in on the computer, and we'll look for calcifications. Next slide. This is an example of what I said was architectural distortion. Architectural distortion is a pulling and irregularity of the typical nice, what we call concave aspect of the mammogram. It looks like a star. This doesn't necessarily only mean there's cancer, but it's a strong finding and suspicious finding for cancer. And so we look for architectural distortion. It's very difficult to see. This is why you have an expert reading a mammogram, because this is probably one of the hardest things to see on the mammogram, is to look for this architectural distortion. Next slide. Now, This is called a developing asymmetry. And what I mean by this is as you go from left to right where the arrows are pointing, you can see there's a subtle change over time with an area of increased density or an asymmetry. This is why it is so important to have your old films. So if you go to a new place for a mammogram, it is very important for you to bring all your old films, not just the year before, but the 2 years before and 3 years before. And why is that important? Because sometimes it's very subtle. A finding is very subtle to see a change over time. And it's best to see the change over time from 3 years ago to today when you'll see the greatest change instead of a subtle change just looking the year before. And this is why sometimes we give, what we do is we tell the patients we don't give an assessment at the end of our report. We say we need to compare to prior studies. So if you change places, if you go to a different place for your mammogram, please remember to bring your CD to the new place so that they can find these subtle changes of developing densities. Next slide. Now I'm going to talk about the density of the breast tissue. And you'll hear a lot about this, especially on the news. And not now everything is COVID, but within the past 5 years, we talked about dense breasts. What is dense breasts? The mammographer, the breast imager, grades the breast tissue in 4 categories. We have fatty, scattered, heterogeneously dense, and extremely dense. The image on the left is fatty breast tissue. You can see there's not much white in there in the breast tissue. This is 10% of all patients will have this fatty breast tissue. This is the type of breast tissue that it's very easy to find breast cancer because a breast cancer is white and it won't be difficult to hide the cancer in fatty tissue. The second one on the left is called scattered fibroglandular tissue. And that has a little more fibroglandular tissue than in the fatty tissue. And still, you can miss a breast cancer because it can be in that white area of the scattered, but it's also it's less difficult than the ones on the right, which are considered dense tissue. So this is scattered. And that's 40% of all patients have scattered, 10% have fatty. Now, the third one, it says heterogeneously dense. Theirs is a combination of fatty tissue, the black, and the white is the fibroglandular tissue. And you can see why cancer can hide there. And 40% of patients have this heterogeneously dense tissue. And then on the right is extremely dense, which is 10% of patients. And a breast cancer can hide in that white tissue. So dense tissue is considered heterogeneously dense and extremely dense. So when you have a mammogram, according to New York state law and many states in the United States, there is a law that says the patients have to know their density. So if you have heterogeneously dense breasts or extremely dense breasts, you will get a letter in the mail that says dense breasts. Talk to your doctor about other options. And the other options would be an ultrasound or an MRI or other tests. Okay, next slide. And the next slide. So this is an example of fatty tissue on the left, dense tissue on the right, and you can see how something white can hide in that dense tissue. Next slide. And this is what it's like for, I don't know if you know Where is Waldo, but this is what it's like for a breast imager, is finding that small cancer and finding Where is Waldo, and he happens to be in the upper left-hand corner. He's hiding there. So you really need to you have to concentrate when you're a breast imager. You need to be in a quiet, dark room, and you're really looking for these subtle findings. Next slide. And this is an example of seeing a small cancer in a fatty breast and a dense breast having breast cancer, and it's a little more difficult. You can see that distortion, that pulling in, and that's a mass in a dense breast tissue. Next slide. And yeah. So breast tissue, so dense tissue hides, can hide and mask breast cancer. It's one of our major limitations of mammography. Also, there's a slight increased risk of breast cancer in people who have dense breasts. And there's been 1 or 2 studies that show that in dense breasts, the cancer is a little more aggressive. Next slide. So how do we get around this dense tissue? We have what's called a 3D mammogram, or digital breast tomosynthesis. It's not really exactly 3D. And this is the new machine that most, in fact, so I lost myself. That most facilities do offer. I can say that with 3D mammography, in the past, it's pretty new, but in the past, when it was first introduced, the insurance companies may not have covered it, but now they're obligated to cover it, and there's very few insurance companies who will not cover the 3D. And what happens is we get a 3-dimensional view of the breasts, and you can see in the right side of the image, we have slices of the breast. So we take away, we're having a slice of the breast tissue, and we're taking away the overlapping dense tissue to find something hiding in this dense tissue. And then we take these slices, and then the computer reconstructs them, and we can see these images by slice. And we recommend that when you do have your mammogram, if it's available, you should have your 3D and a DBT, or digital breast tomosynthesis. Next slide. I wish I had a pointer to show you, but the slide all the way on the left is what a 2D image would look like. And if we zoomed in, we would be able to see that cancer that you can see in the bottom right side when it's magnified on the 3D. But the 3D images can find that cancer. It's a little bit easier to see. Next image. And here's another example. You can see that there's pulling in this breast tissue. We don't have straight lines in the breast. Nothing's ever straight. So when you see straight lines, you should be alarmed. And this is an example of 3D. It's separating the tissue to see that area. And you can see the image on the left, which is the 2D mammogram, really doesn't show it as well. Okay, next slide. And this is just an artist from the Midwest, Bev Doolittle, I think, I forgot her last name. And you can see that these cowboys think they're safe, but in the rocks, you can see that they're being watched. And that's also an example of how, we're looking for breast cancer that's hiding. Next slide. The other, what I said, modalities that we have is ultrasound. So if you have dense breasts, we might tell you, you should schedule a screening ultrasound to look for, to see if things are hiding. So with breast ultrasound, we want to see a mass that is either, we're looking to see if something's a solid mass or a cyst. The one on the left is a simple cyst. We don't worry about cysts. They're very common. They can be in older people or younger people. Typically, they're younger people, but it doesn't. You can have a cyst as an older person. And when I speak older, I mean, I'm not talking about old. I'm talking about 60s, 70s. I'm talking. So cysts can be at any age. The image on the right is a benign mass, benign appearing ultrasound mass. You can see it's smooth. It's oval. Next slide.
Dr. Chinitz, I just want to remind you that it's 1:45. So if you want
oh my God,
about 10, 12 minutes for questions, you've got a couple more minutes.
Okay, keep going. So we'll go faster. Next slide. And this is, and the next slide. These are more malignant looking masses. And here is an MRI that's showing a small cancer lighting up. So we might recommend in patients who have a high risk, or if we're suspicious about something, or if they have a breast cancer, we might recommend a breast MRI to see if they have something else. Next slide. Some people talk about the harms of mammography. And if you're called back for a mammogram, about 10% of patients who have those 4 views are called back for additional images. So you can see that for every 100 women, 90 will be told that everything's normal, 10 will be told that they have to come back. And what does that mean? They'll have additional images. Everything's okay. That's the 6 who are called back. 2, we might say come back in 6 months, and 2 maybe need a biopsy. So it's very uncommon, and we shouldn't call this a risk for a mammogram or a harm of doing mammograms. I think most ladies would rather have a call back than not have finding the breast cancer. Next slide. And this is just more of the same. So this is now for every 1,000 women, only about 5 will have the diagnosis of breast cancer. Next slide. So why is it important to screen? You're going to find the breast cancer early before it has spread. We're going to be easier to treat, and we're going to prevent patients from decrease the risk of dying from breast cancer. Next. I'm not going to discuss the different higher risk and how they should start screening. Next slide. But if you have questions, I can say. Now, in the times of COVID, we are very careful here. Everyone is spaced 6 feet apart. You come for your appointment, you might register in advance. Our center was made to have very few patients waiting at one time, and we have multiple rooms. So we have patients all spread out. No one's next to each other. And it's very safe to come in and have a mammogram. You have your temperature checked before you come. Everyone is wearing a mask. And you shouldn't stop your treatment and looking for breast cancer because of the pandemic. Right now is a good time to come. Okay, next slide. And this is just a summary, and we're all done. We have any questions?
That was great, Dr. Chinitz. A lot of valuable information in there, and especially on the with the dense breasts and what other examinations are available for women. Also, the decrease in the number of women dying, I guess, dying from this, the 40%.
Yes, dying from breast cancer.
That's amazing. That's really a testament to science. So I just have so one question privately is when you had said it's in the genes, is there a test that people can take to see if it is in their genes?
Yes, so patients who have a strong family history of breast cancer can undergo genetic counseling, and we have a geneticist at the hospital. And the genetic counseling will give there's a whole slew of tests, but the main ones that we think about is the BRCA gene, the breast cancer gene, and there's 2 types. So people who have a strong family history or who develop breast cancer very young, they will be sent to a geneticist to see if they have that gene. And then if they do have the gene, we might do still have annual mammography alternating with annual breast MRI every 6 months. That's how we do it with the patients who are at very high risk.
Okay, that's good to know. Anyone else have any questions? No one? Okay. Just one last question on the density of the breast. How would you describe denseness? It doesn't necessarily mean big or small, right? It means how the breast is
right. So that's
structured.
Right. Sorry to interrupt. Dense breasts implies that they're more white. It doesn't matter the size of the breast, and it doesn't matter the body habitus of the patient. So dense breast has nothing to do with weight. It's just the amount of fibroglandular tissue that you have. Now, if you lose weight, in fact, it's the one place where losing weight is not as great, is because we'll have less fat. So it's harder to read the mammogram, but don't gain weight because of that. So, so it has nothing to do with body habitus. And you can't look at somebody and say, oh, they're going to have fatty breasts, they're going to have dense breasts. You just don't know. The mammogram is what tells.
Well, again, thank you so much, Dr. Chinitz. Thank you, Alyssa Holland from New York Presbyterian. Your doctors have not failed us. They've been awesome all the way through. Thank you for joining us during this very busy month, I'm sure, and during this Breast Cancer Awareness Month. Thank you all for coming, and we look forward to holding more very valuable workshops with New York Presbyterian. Thank you to C. Baird, another great partner from Yonkers Public Library, and hopefully we'll have you once again, Doctor.
Okay. Any questions, you can call me privately.
Yes,
Great.
and I just want to say thank you to Dr. Chinitz for a very comprehensive presentation, and to, again, Sally and Z for co-hosting this with us. And I just want to remind everyone on the call here that we do have a presentation on lung cancer screening coming up in November on the 10th with Dr. Roy Oman. So as Dr. Chinitz was pointing out, this is no time to not get a screening if you feel there's a concern that you might have, because it is safe, and we are instituting a lot of protocols to ensure social distancing, et cetera. So stand by for that presentation. Sally and Z will send out information about that coming up. Again, that's going to be focusing on lung cancer screenings. Thank you.
Okay, so thank you, everyone, and have a great afternoon.
Hi, everyone. This is Z from Yonkers Public Library. Thanks so much to Sally Pinto and Alexis and Barbara from NORC. Thank you to our community partners, WJCS, the City of Yonkers Office for the Aging, Westchester County Legislator Ruth Walter, Friends of Crestwood Library, and Yonkers Public Library for making this phenomenal partnership. And we thank each and every one of you for being part of our wellness community. Be well, stay well.